So today, Voices from Oxford is talking to a very interesting researcher here at the University of Oxford, because Dr Anne Kiltie is an associate professor in the Department of Oncology, that is the research department, the teaching department, the clinical department that deals with cancer. And that's where I want to begin, Anne, because I come from the days when for a patient to be told that what they had was cancer was like a great big death sentence. Should people be looking at it this way today, or do you think it's rather different from that?
No, I don't think so nowadays, although you mentioned that in the old days. I'm nearly from that era, because when I was working as a trainee at the Christie Hospital in the 1990s, we used to go to a peripheral clinic, and their patients had to fill in a form with their details, and on the heading it said the Christie Hospital, Manchester. This was often the first time they even knew they'd got cancer.
Because the Christie Hospital was concerned with
cancer, and they knew that, even living in Cumbria.
So they, as it were, knew already.
Yeah.
My goodness, what is happening?
Yeah, and they hadn't even been told they'd got cancer, say, by their surgeon.
Right.
And to them, oh gosh, this is now a death sentence.
Yes.
And then we used to see them in the clinic and have to explain to them, no, that's not the case.
Right.
There are treatments, there are cures available in many cases.
Yes. So do we have an estimate, roughly, of fraction of patients who, on being told that they have a cancer, find that, what should we say, 10 years later they're still alive? How do you represent that?
Well, it depends what specialty you're working in. For example, mine is bladder cancer, with the disease that's gone into the muscle, so the more aggressive form. Right. And usually we can say to people, you've got about a 50-50 chance of being cured from this in the long term. Right. And that usually tends to reassure people, because they're assuming they've got no chance of being cured. 50-50
is not too bad, is it? It's not quite the death sentence.
No, but there's other cancers, early detected breast cancer, things like that have much higher survivals. Testicular cancer in young men, nowadays the treatment in the last sort of decades has really improved treatment for them, and they have a very good survival generally.
So now I want to come to another question which I think a general audience would naturally ask. We're all now educated about genes. Yes. So is it all in our genes? Is it what we do? Is it lifestyle? Or is it much more complicated than either of those views?
I think it's much more complicated, and it's usually a mixture. So there are some cases, for example, the BRCA 1 and 2 cases of breast cancer.
These are breast cancer genes.
That is heavily being influenced by the genetics in that individual and in fact their family, so which is why the family members get screened. But also there are others where it's very heavily dependent on environmental factors. So for example, in the past, bladder cancer was associated with industrial exposures, why in the north of England it was common in the 50s and 60s. But obviously everybody knows about smoking and lung cancer. So Richard Dole, who was the one that did the pioneering work here.
Of course, exactly so, and research that is still continuing today. Yes, so we should see this as a very complicated interaction between our genetic makeup, our lifestyle, the way in which the environment treats us, whether we like it or not, and so on.
That's right.
Yes. Now, final question for you, Anne. Where do you take your research now? You said you worked on bladder cancer. Does that mean that there are good treatments for that? And how do you see that and the way the work's going?
Well, bladder cancer, when it's in the muscle, is either treated by having your bladder removed, which is called a cystectomy, or having radiotherapy-based treatment. And what they found recently is that by adding some chemotherapy to the bladder radiotherapy, this can improve the survival rates.
I see.
And one of the problems with some of the chemotherapy is it's quite toxic to patients.
Indeed, yes.
And we have an elderly population getting increasingly more aged, and we really need to now find treatments that are suitable for these people in their 80s, even their 90s, which we don't have at the moment, and that's part of my research.
So if I understand it right then, the chemotherapy makes the radiotherapy more effective?
Yes,
would that be a good way? Yep. So this is zapping it with two things at once, as it were. How do the patients put up with that?
Well, there are more side effects by adding the chemotherapy, but what we're trying to do is find the agents that are going to have the least additional impact to the radiotherapy.
Yes. Well, Anne Kiltie, thank you very much for talking to Voices from Oxford, and particularly in Balliol College, which is your own college.
Absolutely. Thank you very much.
Thank you.
Thanks.